I'll just talk a little bit about AVM surgery, because I realize this is a medical student forum, and many of you haven't seen an AVM and maybe haven't seen one of these operations before. So I think some of the basics might be helpful. So let me just start with Aruba, because I noticed in a lot of your journals that you selected, this is a theme of the reviews. Aruba is the controversial study that looked at the medical management of AVMs and compared that with any interventional therapy. And you can see from this slide, just in that first line, how the result was that medical management did better. But if you look at Aruba, in practice, what we've noticed being at a neurovascular center is that it's actually driven AVMs to our center, so that if you are a center or a surgical team that focuses on this, you actually think we're helped by the results of the Aruba trial. I think many of the interventionalists and surgeons in the communities who are doing these cases decided after Aruba that maybe they shouldn't be doing them. Maybe if they were going to be done, they should be focused on the results and focused at centers that do this routinely. So we actually saw a bump in our practice, and it's, if anything, centralized AVM surgery. These are some numbers. These are actually out of date. I'm well into the 900s now with my personal series. So quite a bit of experience with these lesions. And one of the things that I did many years ago was to write a book about AVMs. And I just wanted to share with you a little bit of the ideas in the book, because I realize as medical students, this is way too specialized for you to be reading at this stage of the game. But what I wanted to do when I wrote this book was to develop a taxonomy for AVMs, because AVMs, they're so different. Everyone that you see has a different size and shape and location, and it's very easy to fall into this way of thinking that everyone is different, and each one is its own unique problem to solve. But in fact, a taxonomy allows you to categorize these and recognize them as one of a finite number, and then it really helps you to get a handle on these. The second thing I wanted to do in the book was to really look at the surgical strategy, so that the surgical process of removing these was straightforward and understood by everybody. And that was really a way to improve technique and results. So whenever I write my books, I like a metaphor, and war was the metaphor. So you're going to see a lot of that throughout this talk. But this is just a slide to make the point that there's so many different types of AVMs. And when you look at this slide, you can see them everywhere, in the frontal lobe, in the temporal lobe, in the brainstem, in the cerebellum. And so it's very easy to get confused by them. And it really doesn't do you a lot of service to think of them as each being unique. It's much more valuable to think of them as part of an organized system. So we'll do that. I'll show you how I've done that. I also developed these concepts of the battle plan, where you think of an AVM as a cube. It's never actually in that shape, but if you take something as complicated as an AVM and force it into this cube concept, then you can map out all of the arteries and veins that feed or drain the AVM onto different sides of that cube, so that when you're actually doing the work, you can know where to find them, you can anticipate them, and with regards to the veins, you can protect them throughout. These diagrams here just show the different steps, which we'll talk about in just a minute here. But anyway, AVM surgery it's more challenging than aneurysm surgery. These are very difficult lesions to take out. They're difficult to choreograph like we do for aneurysms. And so this is why I think this system is helpful. This is the taxonomy. I like the number 7, so I break things down into 7 different regions, and that's what you see on the left. These are the AVM types, and they just refer to where regionally the AVM is located: frontal, temporal, parieto-occipital, ventricular, deep, brainstem, or cerebellar. And those are your 7 types. And then the subtype is really based on the surface that the AVM lives on. It could be the lateral surface, medial surface, and so on. And the combination of these 2 descriptors gives you your taxonomy, or your label for the AVM. And when you put all this together, you end up with 32 AVM subtypes, and here they are all listed. And just as some examples, you can think of all the AVMs in the frontal lobe, but they really can be categorized into these 5 types: those that are based on the lateral convexity, those that are based here on the medial surface here in the inner hemispheric fissure, those that are on the basal surface, which is over the orbit, those that come to the surface in the sylvian fissure over here. And finally, these paramedian ones are interesting because they're actually a combination of those that are both inner hemispheric and lateral. So it's actually a combination of the lateral and the medial. And we can go down the list. The temporal AVMs have these 4 subtypes: lateral, basal, medial, and sylvian. The parieto-occipital ones have 4 types: the lateral, medial, paramedian, and basal. And ventricular, these are the 4 different types of ventricular ones. Deep regions can be sylvian, insular, basal ganglia, or thalamic. And we can keep marching on. These are just different views of those from above. Here, the brainstem AVMs, midbrain, pons, and medulla, and then different surfaces where they are located. And then finally, cerebellum. So here, there are 3 cerebellar surfaces: the suboccipital surface, the tentorial surface, and the petrosal surface. But then we've got these AVMs here in the vermis, right in the midline, and those in the tonsil down here. So 5 cerebellar subtypes. Now, here's the war analogy here, or metaphor. And when we go to war with AVMs, we have to think of the battlefield, which is our anatomy. We have to think of the battle plan, which is our surgical steps. And we have to think of the enemy, the subtype of AVM that we're fighting. And so these are those steps that I mentioned. And I'll just march you through from exposure to resection. Exposure, here's that concept of the cube. And the idea here is when you're putting together your exposure, you want a big craniotomy. You want to be able to get to each of these 6 sides of the cube. And you want as good of a view of those sides as possible. So you want to make sure that you don't scrimp on your exposure. Here's the next step, subarachnoid dissection. This is really about just kind of opening up the fissures and spaces around the AVM, getting a sense for the arteries and veins. It's really just opening things up, looking for the margins, looking for the planes, opening the fissures. And in the process, what you're really doing is you're taking all of that angiographic anatomy that hopefully you've studied in advance, and you're kind of laying it out there so that you can correlate exactly what feature on the angiogram corresponds to what you're seeing in the surgical field. And that really helps kind of place you in space. It's important to find a draining vein because you've got to preserve it. The AVM has got to have a drainage outlet throughout the resection, otherwise it'll burst and explode. The color of the vein is important because I think of it as a compass. The redder it is, the more work you've got to do. And as it starts to turn blue, it tells you that you're getting close. So that's your odometer. It's telling you how far in the journey you are. The compass is that you can follow an AVM that may not be obvious on the surface of the brain down to where it's hiding under the surface. And so it can lead you there. Next is the feeding arteries. We've got to figure out what arteries are good and what arteries are bad. So we have to look at these different categories of arteries. Some, the terminal artery up here, you see comes into the AVM and ends in it. So you can take those. But then you've got these, what we call transit arteries that go right by the AVM. They send off these little branches, but then they continue onward. So you've got to preserve that distal parent artery so that the flow can continue on. There are these perforators that go through the white matter and feed the tip of the cone. And there's also these choroidal vessels in the ventricular space that go and feed the AVM from underneath. So you've got to be able to recognize what's what, so that as you're working out this puzzle, you don't inadvertently take, for example, this bystander artery that has no contribution to the AVM, but is right nearby. And so these are important. It also helps you in your decisions to manage it. This en passage or transit artery is best dissected from distal to proximal, because if you start at the back end and work your way forward, then you'll preserve that outflow that you're trying to protect. And this is just a picture from a case showing how these arteries that are in transit, they give off these branches. And at the end of your skeletonization, you basically trimmed all of these branches as they feed the aneurysm, and you've protected that distal flow. So we're all the way down to step number 5, and we barely touch the AVM, and this is really where the battle begins. You've got to first take out these peel feeders, the ones that are right on the surface here. You then go down into the parenchyma, and that's where you get into the 4 sides of our cube, where the AVM is kind of buried into the parenchyma. As you get into parenchyma, you have to think about eloquence of the brain tissue. So these areas in color are all areas that have really critical speech or language or motor functions, and you've got to protect those. These are what give eloquence to AVMs in the Spetzner-Martin grading system. You also have to think about the compactness of the AVM. An AVM that's very tightly wound is going to be easy to go around, whereas one that's diffuse is going to have this kind of ragged edge that may not be as easy to differentiate. When you get down to the last side of your cube, the 6th side, it's what I call the ependymal dissection. It's on the deep side, or you can think of it as the dark side of the moon. You've done everything in the light here, but the part that's in the dark here is the hardest to see. You've got to move the AVM around. You've got the deep white matter feeders that you're having to tackle there. And so it's really the most challenging part of the case. And some of the tricks are to use TELFA to protect the brain, use retractors liberally, use these AVM microclips for little perforating feeders that don't coagulate. And then finally, just really deciding exactly where to make that turn and get around the bottom of this. If you cut it short, you'll have a little remnant here, whereas if you go all the way down to the ventricle, you'll get around this fully. And finally, at the end, you can see here, this AVM has been completely circumdissected. The vein draining it is now blue, and you can just sort of pull it out, and it's like a little trophy on a string, and you're done. These are the battle plans. The battle plans are basically just all those different steps in action. And let me just find a good case here for you. Yeah, so this is the dissection to the AVM. So what I'm doing here is just coming down in between the frontal lobes. So I've got the left frontal lobe up at the top and the right frontal lobe at the bottom. And I'm just going to just show you the cool parts here at the end. The idea here is when you do this approach, the space between the 2 frontal lobes is this very thin, narrow canyon. And as I go down that canyon, I've got to get around the outside of this AVM. So here's that plane between the deep white matter over here and the AVM here. You see how the AVM just kind of falls towards me? And I've got my sucker instrument on the AVM. I'm kind of pulling it down, and I'm able to see into the hole. So this is just a trick where we use gravity to make our views better. The hard part of AVM surgery is just seeing what you need to see. And here's where we need to see, right in this little space here between where the AVM ends and the brain starts. Oops.
Notice from the MRI, also have the very large AVMs.
Are you seeing the video there?
Yes.
Yeah. So here's just at the very end, dividing the draining vein. And you'll see as this AVM comes out, you almost don't see the AVM until when I take it out, you can see how big it is. So there it is at the end. And the idea is it's been taken out through this very small space, and using the head position, using gravity, using these nice instruments with the light on the tip, it allows me to kind of get into those deep spaces and safely remove it from the frontal white matter. Here's one frontal lobe, here's the other, the nose is up here, and here's our resection. You can see how there's our cavity from the AVM. We've protected all this brain by not going through it. And angiographically, it's all taken care of. So I'm just going to finish here since I'm at 30 minutes. And just these are kind of my concluding thoughts for you to think about. Intervention for unruptured AVMs is now considered risky thanks to this Aruba trial. But in my view, the surgical indications are strong, particularly for the smaller, low-grade AVMs. I use embolization, which is the intervention to close feeding arteries. I use that as a preoperative adjunct, and I don't use it as a curative step. And then as far as radiosurgery is concerned, I reserve that for AVMs that I don't think are good open surgical candidates. And I use it almost as a second line therapy rather than the first line. And I also use it for some of the large AVMs that we just want to shrink a bit. So that's my use of radiation. And then finally, you know, we really have to focus on our results because we're kind of under the gun with all of these studies like Aruba, where we're being challenged in our surgical management. So I want to stop there because I think it's more fun to talk about things and let you guys do some presenting.
Awesome. Thank you so much, Dr. Lawton. So we're going to transition to the medical student presentation. So Sarah and Mike, you guys can get your slides up whenever you're ready.
All right, thank you. So Mike and I are excited to be presenting this really important, but also, as Dr. Lawton said, a very controversial paper tonight. It's really hard to spend much time in any neurosurgery vascular meeting, whether it's local or at a national conference, without hearing a variety of kind of passionate opinions about the Aruba study. The original study was actually published in 2014, but the paper that we're presenting tonight is an update with extended follow-up period that was just recently published in 2020. So just as background to this study, some basic reminders about AVMs. Obviously, Dr. Lawton did a beautiful job covering these. These are just vascular lesions in which arteries connect directly to veins without the normal intervening capillary system. And this is a problem locally because oxygenated blood is shunted out of the arterial supply. And it's also a problem globally because these abnormal vessels are somewhat prone to rupture and cause a hemorrhage. And AVMs that rupture have a mortality rate of around 10%. Also a reminder of the original Spetzler-Martin grading scale for AVMs. This has since been expanded and updated. We now also have the Lawton-Young scale as well. But for the purposes of this study, they used the original Spetzler-Martin scoring system in their analysis. So the Aruba study was originally designed to determine if medical management alone was either superior or non-inferior to medical management plus any type of intervention. This included neurosurgery, embolization, or radiosurgery, whether alone or in any combination of those interventions. One important factor to consider is that these different interventions have been shown in various systematic reviews to have very different outcomes and rates of effectiveness. From in the 30s percent for embolization alone, up to 95% for embolization followed by microsurgery. So there's a very wide range there of effectiveness. And medical management for this study was defined as just pharmacological therapy to treat any neurological symptoms as needed by the patient. So none of the medications given as part of the study were aimed at treating the AVM per se, but were used exclusively for relief of symptoms that are caused by the AVM. So a lot of the controversy surrounding the Aruba trial centers around the methods or the structure of this study. So we'll review that a little bit here. The trial was randomized as a prospective study carried out at 39 treatment centers across 9 countries. And to be eligible for the study, patients had to meet 3 criteria. They needed to have an unruptured brain AVM. They needed to have never undergone any interventional therapy for that AVM, and to be considered suitable for intervention by a provider at their local participating clinical center. So that was a source of a lot of variation as well. In the end, of the over 1,700 patients who were originally screened, 1,514 patients were excluded from the trial, and 226 were included in the trial and randomized. At 1 year, there were 107 in the medical management arm and 110 in the interventional arm in the original 2014 study. The 2020 follow-up examined outcome data at 5 years out, and for that data range, they had remaining 45 patients in the medical arm and 41 in the intervention arm. Now Mike will go over the results of the study.
Thanks, Sarah. Okay, so looking at the primary outcomes, so the primary outcomes in this Aruba trial were symptomatic stroke or death. And it's important to note that the definition of symptomatic stroke used in the study was fairly broadly inclusive and was defined as occurrence of any clinical symptom, including seizure or new onset headache in association with new intracranial blood or a new ischemic lesion on CT or MRI. And the rationale that they provided for this was that most of these lesions are asymptomatic at baseline, so that any deviation from this normal baseline would represent a negative effect attributable to the intervention, even if relatively minor. So based on this definition, primary outcomes occurred in 15 of the 110 patients in the medical management group, which represented an incidence of 3.39 per 100 patient years. This was compared to 41 primary outcomes in 116 patients in the interventional therapy group, which represented an incidence of 12.32 per 100 patient years. And this worked out to be a hazards ratio of 0.31 in favor of reduced risk of primary outcome in the medical management group. And looking over here at the curve on the right, so in the interventional therapy shown in the blue line, there's a pretty striking rise in complication or in the occurrence of primary outcome within the first 6 months. That relatively stabilizes to a plateau by 18 months. And what this is suggesting is that a lot of these kind of post-procedural complications are being caught up front in the beginning of the trial. But theoretically, as the AVM is eradicated, the risk of a primary outcome would reach a nadir towards the end of the period. In contrast, the medical management would show a gradual increase in risk of primary outcome since there was no treatment for the AVM. And we know that the natural history is about a 2 to 4% annual rupture risk. So we're going to see that cumulative risk over time. Okay, so the secondary outcomes, so there were 2 key secondary outcomes that they looked at, and these were death or significant disability at 5 years. And they defined significant disability as a modified Rankin score of greater than or equal to 2. And notably, so the data here was only available for about half of the patients. It was 45 in the interventional group and 51 in the medical management group. And this has been an important criticism of the trial, and that there was significant dropout and non-availability of this long-term data. So of those patients, 17 in the interventional group, which accounted for 38%, had a modified Rankin score of at least 2, compared to 9 patients or 18% in the medical management group. Other pre-specified adverse effects were asymptomatic or symptomatic stroke, focal deficit, which was not attributed to a stroke, seizure, headache, and other additional procedure-related events, which are shown here on the right table. In aggregate, the adverse effects or secondary outcomes occurred at a lower rate in the medical management group with a risk difference of negative 19.76. So Overall, subgroup analysis demonstrated considerable favorability of the medical management, but there are some important exceptions that provide some important insight into the way that the trial is conducted and potential kind of confounding variables. So first off, Spetzler-Martin grade lesions actually demonstrated a trend towards reduced risk in the interventional therapy, although there was crossing of just one threshold, so it wasn't significant. AVM size less than 3 centimeters also was not significant, although trend towards medical management. Same for superficial venous drainage only. Interestingly, this treatment in an Aruba West location, which suggests that there might be some differences in the management strategies that were employed in Aruba West versus European sites, which perhaps Dr. Walton can talk about afterwards. So what this might suggest is that some of these lower grade lesions, which are known to be favorable for microsurgery, did not actually have significant higher risk of negative outcomes. And that has some implications for the type of management strategies that were employed. And that becomes more obvious when we look at the intervention breakdown here. So for a neurosurgical trial, it was fairly non-surgical in that only 21% of patients underwent surgical resection, 54% underwent radiosurgery, and 62% underwent endovascular embolization. So there was a really strong predominance of embolization in this group, which is known to be associated with complications, particularly when trying to go for a really aggressive approach at cure. Importantly, the surgical resection demonstrated a really strong cure rate. So 95%, 21 out of 22 surgically resected treatments demonstrated eradication versus only 21% for the radiosurgery alone or in combination, and 52% for the embolization group alone or in combination. So in conclusion, this extension from an average of 33 months follow-up to 50 months follow-up maintained the superiority that was seen in the original Aruba trial of medical management for cerebral AVMs, specifically within this Aruba cohort. And a takeaway from this is, practically in counseling patients, it's important to discuss these relative and absolute risks of intervention that were identified in this study, but also to counter that with the known natural history of these lesions, and have a shared decision with the patient on choosing the appropriate therapy or if therapy should be done. And Dr. Lawton provided some evidence too as well for the kind of having these procedures done at a center of excellence, or high volume centers. While this study was an important first step to identifying appropriate treatment paradigms, there's a number of limitations that prevent broad generalizability of this study. So first off, as mentioned earlier, the definition of stroke as a primary outcome was fairly broad. And this was defined as neurological deficit with any findings on imaging. So it's likely that a lot of the patients in the intervention group, were having these post-procedural complications caught early. And that's emphasized by the fact that there was from the time of intervention to a primary outcome, the median time point was 1 day. So it suggested that these were post-procedural complications, which simply could have been a patient with evidence of postoperative bleed and a headache, which might resolve in time. Moreover, there was a smaller than intended sample size as well as number of centers. So originally it was proposed that there would be 800 patients at over 100 centers. It ended up working out to 216 patients in, I think it was 39 centers, so much smaller than intended. And finally, we saw this bias towards lower Spetzler-Martin grade lesions, yet there was a low rate of surgical resection, which is interesting and suggests there might have been some treatment selection bias, as there was treatment mismatch between lesions known to be preferable to surgical resection that weren't treated surgically.
So following the original Aruba trial publications, several single center follow-up studies and reviews have been done using patients who would have qualified as eligible for inclusion in the Aruba trial. which have drawn somewhat different conclusions, and some have shown lower rates of unfavorable outcomes with interventions than were originally reported in RUBA. Also, future trials have been proposed with different criteria for inclusion of patients, also standardized intervention methods and more precisely defined outcome measures, as Mike was just describing. And so in all, this was really a landmark study, which has given neurosurgeons a lot to discuss over the past decade regarding treatment of unruptured AVMs. And thank you for allowing us to present.
Yeah, thank you so much. And we just wanted to put this up as well, as some future directions which have been proposed, in particular, this idea of a Barbados after Aruba trial, which perhaps we could talk more about.
Yeah, so nice summary. It's hard for me to know where to begin. The Aruba study, none of us liked it. And I think the problem is what you presented. If you think back to my talk, my belief is that AVMs are a surgical disease. And if AVMs are very carefully selected for operability based on specimen-Martin grading and supplementary grading, then you can really do a nice job at picking those AVMs that are going to do well. You obviously need to have a lot of surgical confidence and experience to get good results, but I think the combination of careful patient selection and good technique means that when managed surgically, these patients do really well. The problem with Aruba is that so few of these patients were not operated, 21%. And that's just a sort of the real travesty of the trial is that most of the intervention in the interventional arm was embolization, which is, rarely curative. The 50% cure rate that they reported is really quite good. It's far in excess of what we were seeing pre-Aruba. But I also think that some of the morbidity, some of the primary endpoints that were counted against the interventional arm were because, when you push something that's really not so great for curing an AVM, when you push it hard, you're going to get complications. And so it's clear to me that a lot of the AVM management in the trial was endovascular and pushed too hard to the point where the complication rates were higher than they should have been. And second, radiosurgery, as we all know, is it's a therapy that takes time to do its thing, and the interval here was very short. So these AVMs were not well cured. 21%, I think, is what your slide said, or something really quite low in the 20% range, and that means that AVMs treated with radiosurgery had the ability to continue to bleed and cause trouble. So I think it's that's really what led me and others to think about this Barbados idea, which was basically just a surgery first trial. The idea being, if you get surgeons who had very extensive experience, we're going to set the bar very high to surgeons who are doing 30 or more AVMs per year, and had good results, good technique, good selection criteria, and use them as the benchmark, and not all of this other stuff, this radiosurgical and endovascular therapy. Then if we put that up against medical management, then I think the results would be far different. And those papers that you alluded to after Aruba were basically showing just that. It was sort of a retrospective Barbados, where each center just looked at its low Spetzler-Martin grade AVM results, and they were really quite good. These were the grade 1s and the grade 2s. These were all Aruba eligible, and the results were far different. So that's kind of my take on Aruba. It doesn't surprise me that the follow-up study is no different than the original study. There's no reason why it should be. But just because you have longer follow-up doesn't mean that the results are any more relevant or important.
Awesome. Thank you guys so much, Sarah and Michael, for those presentations. We're going to proceed to the next set of medical students. We have Christina and Patricia who are going to present. And I promoted you guys to co-host, so you guys should be able to share your slides. And sorry, we just may need to speed it up a little bit, just go a little faster than before, just for sake of time, unfortunately.
Yeah, I have a meeting that I need to go to right after 7, so
Definitely.
whatever you can cram in before then is great.
Perfect.
Okay, I'll try to be quick. So we reviewed the RAG study. We can go to background. And so, as we all know, rupture AVMs are a neurosurgical emergency with high morbidity and mortality. However, there's no universal grading system for clinical outcomes. What is the current method is that different scales are applied, whether that be the Hunt and Hess, or, sorry, back one slide, the World Federation of Neurological Surgeons, or trauma Glasgow scale, ICH score, or the Spitzer-Marson and the supplementing AVM scale. Next slide. And so the objective of this study was to develop an all-comers scoring system to grade patients with rupture AVMs in order to predict a more clinical outcome that's accurate. The literature suggests that outcomes for AVM ruptures are superior to aneurysms and hypertensive hemorrhages. However, there isn't a grade system that shows that grade for grade. And so they use an extension, the H&H scale, and this outperformed the current grading system, and it was able to predict clinical outcomes regardless of the intervention. And so in order to develop their system, they use the patients at, if they had loss of consciousness and how they presented when they first got on the scene, and they use that with the H&H scale. And then they looked at the deep venous drainage and the eloquence using the Spitzer-Marson scale, and they also use age. And so this is just a slide talking about the methods. There are only 115 patients were selected using, this was a retrospective chart review study, and they excluded unruptured AVMs and incomplete records and lost the follow-up. They used only 2 authors. One did all the radiology data and one did all the clinical data for completeness. And then they were able to use statistical analysis, and the study variables were from admission. They used H&H grade, DCS, WFHS. They used age and sex, past medical history of hypertension and diabetes, smoking status, and they also used the Spitzer-Marson and supplementary AVM scale. Next slide.
Okay, so for the results, this is just an overview. Demographically, the average follow-up time is 4 years. And just like Christina has mentioned, total of 115 patients that were treated between the year of 2002 and 2018, and Brigham Women's Hospital were included in this study. And 53% of the patients included in the study were female, with the average AVM size being 2.2 centimeter. And then these are just some of the detailed information of the study. For the sake of time, I'm not going to discuss further. And then in order to identify reliable predictors, regression analysis were performed, and the study team identified age, deep venous drainage, as well as the eloquent location as reliable predictors. That's what were shown in this table. And then unsurprisingly, you can see like older age is associated with worse outcomes. So the verification was performed by first predicting the score at different follow-up checkpoints, either at 3 to 6 months after rupture AVM or 9 months to 1 year. And then second, by applying this grading scale to a dichotomized clinical outcome with a score of 0 to 2 being favorable and 3 to 6 being unfavorable. And then based on the area under the curve analysis, you can see the REG score grading scale outperform all the other currently existing grading scales that have been used for AVM. And this is a key finding. So this study concluded that this REG score was specifically designed and tailored for AVM rupture and then to predict clinical outcome. And it outperformed all the other currently available grading scales. And the calculating of this score actually required a patient to have already undergone vascular imaging. But this is not a barrier for the study since this is typically acquired as a routine AVM workflow. And limitation-wise, as this is a single institution retrospective study, unsurprisingly, the generalizability of this grading scale will need to be further validated with external data from other institutions. And then future studies should consider incorporating more objective measures as well as improve the generalizability of this grading scale. So conclusion-wise, taken together, this paper concluded REG score is a specific grading scale that's tailored to predict clinical outcomes of rupture AVM. However, this grading scale should be used with caution to just predict clinical outcome, not surgical outcome. And that's all what we have. Thank you for letting us present this.
Yeah, nice presentation. So, yeah, I know the authors of this grading scale, and I think it's a nice piece of work. It does give higher accuracy in their data. So I think you could argue that perhaps we should be using it. But here's my beef with it. You know, things like Spetzler-Martin grading system and my Lawton-Young or supplementary grading system, you know, they have all of these things in them. What the RAGS does is it takes pieces from each and just reassembles them in a way, adds it to the Hunt and Hess grading system, and carves it out for just a very selected subgroup of the ruptured AVMs. You know, I think it doesn't doing us a huge service to just pick and choose amongst the variables. I think it's probably better for us to.
Okay, so hello, my name is Nick. I'm a third-year med student at UT Southwestern, and Siyun Yu is going to be presenting with me. He's also a third year at Cooper Medical School. And so today we're going to be covering actually one of Dr. Lawton's recent articles on preoperative embolization for specifically grade 3 AVMs. So this was a study out of Barrow and UCSF, and it was published in the Red Journal recently in 2021. Go to the next slide. So to just cover some background, which has already been, kind of talked about, so I'll kind of go over quickly. Grading of AVMs is usually divided into the, Spetzler-Martin classic grading score and the supplementary grading, with most of those points assigned in the Spetzler-Martin classic grading system based on the size, and some additional points for venous drainage and eloquence of the nidus location. And on the right, you'll see some examples of grade 1 through 4 AVMs. And I think the grade 3 picture is a nice example of a very deep-seated nidus with some, very deep venous drainage. And on the right, those are the three kind of classic interventions we think about for treatment. So microsurgery, embolization of the feeding arteries as a surgical adjunct, and radiosurgery is rarely used. Next slide. And then another important thing to cover just before we get into the study, because they used it for outcomes, is the modified Rankin scale, which is a score of basically a measure of disability. It ranges from 0, which is no neurological symptoms at all, and 6, which is someone who's passed away. And so you'll see a nice cutoff point between 2 and 3, which is where, score 2, someone has slight disabilities, but able to, take care of all their kind of activities of daily living on their own. But 3 is when people start to require assistance. And so the division between score 0 to 2 and 3 to 6 usually define good and bad outcome respectively, with 1 and 2 having some subjectivity between them, and same with 3 to 5. So the cutoff between 2 and 3 is a nice way to say good and bad outcome, and that's how this study kind of dichotomized good and bad outcome. Next slide.
Okay, so just a little bit more background on the study. As Dr. Lawton already mentioned, grade 1 and 2 are generally surgically managed. And essentially for this paper, what they really brought up the importance was the operative management of grade 3s. And here you can see some of the literature that have talked about embolization, because grade 3 AVMs are not, there's no general consensus on whether preoperative embolization will help or not. So some studies in prior that have studied preoperative embolization versus direct surgical management of all grades of AVMs. Some papers have shown that preoperative embolization is associated with decrease in size and better functional outcome, whereas the more recent studies looking across different grades of AVMs have shown that there's no functional difference in outcome, and some have even shown that there's higher complications associated with preoperative embolization. Okay, and to go further on the background, Dr. Lawton in 2003 published this paper essentially talking about the heterogeneity of grade 3 AVMs. As Nick had mentioned within his grade, within the different breakdown of grades, grade 3 AVMs actually comes in different flavors, and there's 3 flavors that Dr. Lawton specified was the -2 to plus, and as you can see here, grade 3s can be broken down further, and the S2V0E1, when in their subgroup, actually had the worst mortality and morbidity when compared to the other grade 3 AVMs. And recently there have been papers looking at grade 3 AVMs with preoperative embolization alone, and they have essentially shown there's pretty good outcome and surgical resection afterwards. However, the problem really is that there have been limited data comparing direct preoperative embolization versus direct surgery and their outcomes. Therefore, our study here really tries to address the question whether grade 3 AVMs with or without preoperative embolization leads to better outcome. And here's the methods. So there's a retrospective study of 2 centers, and essentially patients were divided into embolization versus no embolization plus surgery. And to take into account the heterogeneity of the groups, a propensity match was done, and here are the variables. They propensity match after the analysis. And the primary objective of the study, as Nick had mentioned, was the of the patients with greater than 2 MRS score, which signifies a bad functional outcome. And the secondary objective was to measure the intraoperative bleeding and change from preoperative to postoperative MRS scores. And here are some patient characteristics. So you can see here, there's no difference in age or ethnicity. And we look at further, there's no difference in nidus size, no difference in supplemental Spencer-Martin score. However, there's difference in the elegance of the cortex, with favoring the non-embolized group, as well as the size of the AVM was larger in the embolized group. And when we look at some of the primary outcomes, there were no difference in preoperative MRS score, so they had the same function starting off. And when we look at the primary outcome, we see that in the embolized group, the patients did significantly better in terms of the postoperative MRS score of patients with greater than 2, a lot fewer. And the mean follow-up was about a year, and there were similar amount of complications in both groups.
Yeah, so to go into a little bit more detail on their primary outcomes, you can see in the time of point of last follow-up in the embolization group, only 7% of patients in this group had an MRS greater than 2, considering a bad outcome, whereas 38% of patients had an MRS score greater than 2 in a non-embolization cohort. And as you can see, this was significant. And if you take this at face value, the number needed to treat based on that odds ratio is only 4 patients, which is really good. And while it didn't reach statistical significance, MRS worsened in 42% of the non-embolized cohort versus 26% of the embolized. Given the kind of the confidence interval of that odds ratio, obviously it passes 1, so it's not statistically significant, but it probably is clinically significant given the kind of absolute difference on those proportions. And then they did a propensity match, which, like he said, matched for patients up by a number of heterogeneous variables. And again, they saw that resection without preoperative embolization was a risk factor for poor outcome. You can go next slide. This table just shows some of the embolization characteristics. I'll cover quickly. Some patients got different types of embolization glue. I think the important takeaways from this table was that some portion of people in the embolization group got multiple embolizations prior to surgery, and the complication rate was very low for embolizations, but complications did occur. And again, the nice thing about this was that the time from embolization to surgery was very short. Next slide. So this study has a number of important limitations. First of all, embolization was, the non-embolization cohort, was set up potentially for a higher risk of complications because in that group, there were more eloquent lesions and there were more diffuse AVMs. So there's definitely a little bit of selection bias here, which the authors do acknowledge. However, the supplementary AVM score is similar between the groups. Then another thing the study really didn't comment on was how many embolizations are safe, and they didn't really report on what the MRS was for people who got multiple embolizations. So that might be something interesting to look at in the future. Another thing was that preoperative MRS scores, while they were non-different, when they're chi-square that they did, if you dichotomize them into good and bad outcomes preoperatively, there was a slight favoring towards the embolization group already kind of being set up to have potentially a lower MRS score from the get-go. And while they did propensity match for a number of characteristics, which is good because AVMs are a very heterogeneous disease, this only controls for the variables that you input into the propensity match and is not as good as randomization. And then again, this was done out of UCSF and Barrow, which are great neurovascular centers, so the results might not generalize to other neurovascular centers. You can go to the next slide.
Okay, yeah. So in conclusion, what the paper and Dr. Lawton concluded from this paper is that preoperative embolization, it could be safe. And from the study itself, while it's not conclusive, it does suggest that preoperative embolization is associated with better functional outcome. And furthermore, the paper suggested that for AVMs with large size, high flow, and surgical inaccessibility of the feeding artery, preoperative embolization of grade 3 AVMs should especially be considered. Another point the paper brought up was that as surgeons become more experienced, they rely more on their own experience rather than having to take on the increased risk of the preoperative embolization, that procedure alone. However, this paper argues that no matter the surgeon's level of experience, preoperative embolization was shown to be safe with low complication and should be considered for all surgeons. And for future directions, the subgroup analysis, the S1B1E1, showed a much higher risk of complication with surgical alone. In their prior studies, they have shown that the S1B1E1 had much lower complication. So it's unclear why there was so much higher complication in this study, and that is a future aim for the authors to look into. Additionally, as I had mentioned before, a grade 3 AVMs really is heterogeneous within its own grade, and it would be very beneficial to further categorize a treatment algorithm to management of subtypes of grade 3 AVMs. And lastly, as Nick had mentioned, because of the surgical experience, if this could be available to more centers, then the generalizability of this study could be will be better characterized. And that's our talk. Thank you.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.